Hello students. Today in this lecture we are going to again talk about regional anesthesia, its safety, the complications we face in regional anesthesia, how to diagnose the complications and how to manage them. There is a profound cardiovascular effect of regional anesthesia because of the spinal sympathetic chain due to the regional anesthesia is blocked. So what happens? The sympathetic supply to the vessels, the veins and the arteries are stopped. Arteries have a thick muscular wall, but veins have a very thin muscular wall. So arteries, the muscle itself can take care of the part of the constriction or dilatation. But veins being very thin walled, they dilate because of lack of sympathetic stimulation. So due to venodilatation, what happens is the venous return from the legs upward, which is basically the major supply of venous blood, becomes less. So there is venous pooling all the way from the heart down into the legs. As a result of the venous return being less, there is less blood in the artery, so the stroke volume also decreases, and when the stroke volume decreases, the cardiac output also decreases, and when the cardiac output decreases, the blood pressure decreases. So one after one this happens. If suppose we block in the upper region of the thoracic vertebrae, sometimes we have to give a thoracic epidural to block anything below that. Or in cases of a patient who needs an epidural for a small chest surgery. So due to the sympathetic supply being blocked, the vagus, so you know that the sympathetic chain is the craniosacral chain along the vertebrae, and the parasympathetic are the part is in the coccyx and part is in the central nerves. The major central nerve which has parasympathetic supply is vagus. So sympathetic supply being less, there is unopposed vagal stimulation. Vagal stimulation causes bradycardia because it stimulates the pacemaker of the heart. If there is bradycardia, the venous return being less, what happens is this adds to the lowering of blood pressure because the venous return to right atrium is decreased and the stretch receptor response is also decreased. In short, hypotension is due to sympathetic blockade. When there is hypotension, Mary's law comes into effect. What does Mary's law say? Heart rate is inversely proportional to BP. So when the BP decreases, the heart rate increases. But in regional anesthesia, another reflex which is very important called Bain-Bridge reflex comes into play. What does Bain-Bridge reflex do? It causes bradycardia. The blood pressure leading to tachycardia, the Bain-Bridge reflex causes bradycardia. If there is a balance, then the pulse rate remains the same. If there is imbalance, each one of them gets upper hand. So the patient may have tachycardia, may have bradycardia. But usually Bain-Bridge reflex is more profound, its response is more profound. So usually what happens is bradycardia. Other different settings are oral anticoagulants, where the international normalizing ratio INR and the prothrombin time is taken into account. When the patient is on oral anticoagulant, both INR and prothrombin time increases. How does it is caused? Because of antiplatelet drugs like ticlopidine, which the effect lasts for 14 days, clopidogrel, the effect lasts for 7 days, and there are other drugs which are not available in India which have much more profound effect. So what we usually do is, what we usually find is clopidogrel. Clopidogrel acts for 7 days. So when the patient is on clopidogrel, we wait for 7 days if there is no emergency. In emergency, we'll have to operate. We're taking all the risks into account. So clopidogrel, we stop for 7 days and then we operate. The patient may be on unfractionated heparin, but these days we don't give unfractionated heparin. We usually use low molecular weight heparin. These are much better than unfractionated heparin. When we have a low molecular weight heparin, a low dose of this has little effect, little contraindication. We may need systemic heparin intraoperatively if the block is given 1 hour before. Just let me explain. A block is given, and if the patient has to be on heparin, there should be a gap between the heparin dose and the block for at least 1 hour. If the patient has activated prothrombin time, we should avoid regional anesthesia. In certain cases, due to certain conditions, there can be a high neural blockade. What is meant by high neural blockade? We give the regional at usually the lumbar, sometimes in the thoracic vertebra level. But suppose the drug travels upwards and hits the medulla. So the medulla has all the vital centers of the body. So the respiratory center is there, the cardiovascular center is there. What happens is, because of high neural blockade, and of course there is a blockade of all the 4 limbs, nerve supply to all the 4 limbs, which can lead to tingling and numbness of the upper extremity if the blockade is not profound. But if the blockade is profound, there will be paralysis of the upper limb. Nausea and vomiting due to the hypotension is there because there is a stimulation of central chemoreceptor trigger zone, which is the vomiting center. But in mild to moderate hypotension, these effects are not there. What is the management of high neural blockade? Change the position if the patient has been on hyperbaric technique. That is, if the spinal fluid is less heavier than the fluid, the injection we have given. We had spoken about isobaric, hypobaric and hyperbaric drugs before. So what we do is, we put the patient on Trendelenburg position reversed. What is reverse Trendelenburg position? Is we put the patient feet down, head up. This is Trendelenburg, head down, feet up. These are the Fowler and semi-Fowler position. Coming back to management, stop the administration of local anesthetic if it is an epidural technique. Supplement oxygen. Use IV fluids liberally. If you use plasma volume expanders, it is better. Along with the normal dextrose ringers or dextrose normal saline. If the blood pressure doesn't come up, then we should give intravenous ephedrine or phenylephrine for vasoconstricting the vessels. For bradycardia treatment, we can use glycopyrrolate or atropine. In cases where there is a blockade of S2 to S4, that is sacral 2 to 4, the parasympathetic ganglion are blocked. This decreases to decreased bladder tone and inhibition of normal voiding reflex. Also, what we do, we use opioids as adjuvants during our spinal or epidural anesthesia. These also contribute to the urinary retention. This is of course more common in elderly because they usually have a benign prostatic hypertrophy. Urinary catheter should be provided for patients undergoing moderate to lengthy procedures so that the bladder remains empty. Postoperatively, the patient should be assessed regularly till the catheter is removed, and the patient can normally void urine. If there is a prolonged urinary retention, there may be signs of serious neurological injury. Mind you, there can be serious neurological injury if there is urinary retention for a prolonged time. So we should not let the urinary retention to be prolonged by catheterizing the patient. The needle placement of catheter in epidural anesthesia is very important. If the needle placement punctures the dura and we give the drug, in epidural we give a lot more drug compared to spinal, so there can be total spinal. We'll talk about it later. There can be patchy or inadequate anesthesia or analgesia. Some vessels may be punctured leading to intravascular injection, which is deadly. And of course, subdural injection is what leads to total spinal. Patient can complain of backache because the epidural needle is a very thick caliber, 16 to 18 gauge, while in spinal needle we use 25 to 27 gauge, very thin needle. Because of the dural puncture in epidural, there can be post-dural puncture headache, which we are going to talk later on. Neurological injury can occur in patients because the nerve, the spinal cord can be damaged due to the thick nerve, the thick needle. There can be hematoma inside the arachnoid space, subarachnoid space, or outside. There can be, if there is some infection which is going in when the sepsis is not adequate, there can be meningitis and arachnoiditis, which are very, very bad complications. There can be an epidural abscess. Similarly, if there is less aseptic precaution taken. Once we put in the epidural catheter, while pulling it out, a part may remain inside, shearing. So that part remains inside the epidural space and may later on, because it is a foreign body, may later on lead to complications like abscess and foreign body pain. There can be inadequate analgesia or anesthesia, as we have discussed in the last slide, because this can be due to anatomical factors like anatomical defect inside the spine. It is a blind procedure, so we don't know if there are anatomical separation of the spinal cord or the spinal fluid. So there can be patchy anesthesia or analgesia. Inadvertent intravascular injection can occur. We don't realize that we have given it inside the vessel. The toxicity can lead to CNS or cardiovascular system toxicity. There can be symptoms of hypotension, arrhythmias, cardiovascular collapse, seizures, or in worst cases unconsciousness. How do you treat local anesthetic toxicity? With intravenous intralipid solution, enough of fluid and plasma volume expanders. Just the treatment should be symptomatic. Continuing, there can be a subdural injection, usually in epidural anesthesia. So the large dose can lead to what we call total spinal. We are going to discuss it now. There can be backache. As I said, the thick needle can cause backache which lasts for a long time, if not for life. Postdural puncture headache. Because the needle is thick-walled, 16 or 18 gauge, when it punctures the dura, it leaves a permanent gap in the dura and the CSF keeps on flowing out from the subarachnoid space. So what happens is, due to this low CSF pressure inside the brain, there can be headache. There can be a decrease in intracranial pressure. When the patient sits upright, there can be a traction of the dura, the tentorium, and the blood vessels, leading to intense pain in the neck and in the head. The worst thing is when the pressure down in the spinal system is less, the medulla can cone through the foramen magnum. This all leads to traction on the sixth cranial nerve. You know what is the sixth cranial nerve? It is the longest cranial nerve. So when there is medullary coning, there is traction and the sixth cranial nerve is involved, which causes diplopia and tinnitus. Headache may be bilateral, may be frontal, may be retroorbital, may be occipital. There can or may not be a neck pain there. Headache is usually described as throbbing or constant. This can be associated with photophobia and or nausea. The onset of postdural puncture headache is 12 to 72 hours after the dural puncture, and if left untreated can last for weeks. The patient will not be able to sit up. When the patient is lying down, the headache is less. As soon as the patient sits up, the headache becomes very severe. The headache is in PDPH is more in younger patients, in female patients, and in pregnant patients more. What is the treatment of PDPH? Patient must lie supine for a pretty long time. Patient should be hydrated. Intravenous hydration should be adequate. Hydration per oral also should be adequate. Analgesics like paracetamol are of help but not very profound help. NSAIDs may or may not be given because of the patient eats less and there is a chance of gastritis. Caffeine coffee is a vasoconstrictor. It may be given, and in some cases caffeine works. IV caffeine may be administered in doses of 500 mg. Oral coffee should be encouraged. Patient should get a stool softening agent so that the patient does not have to use strength to pass stool, because if the patient uses strength to pass stool, the headache increases. Lastly but not least, epidural blood patch. It is generally offered 12 to 24 hours after the headache starts. We should check the coagulation profile of the patient before giving an epidural blood patch. No anticoagulant should be administered. Patient should not have septicemia or bacteremia. The epidural blood patch should be given how? Draw blood from a vein and again put a spinal needle through the lower one space below the epidural puncture space and give 15 to 20 milliliter of blood, huge amount of blood into the epidural space. This can increase the chance of meningitis. Otherwise, it is effective in 95% cases. There are other less encountered complications like neurological injury, spinal or epidural hematoma, meningitis, arachnoiditis, epidural abscess, transient neurological symptoms which pass off after a while, cauda equina syndrome. We are not going to discuss cauda equina syndrome. It is a terrible condition. And patient, if they are allergic to the drug, there can be an allergic reaction. What are the disadvantages of epidural anesthesia or the plus points of epidural anesthesia? The plus point is that the blood pressure can be kept in a normal level with epidural, unlike in spinal, because one bolus dose is given in spinal, so blood pressure cannot be controlled. In epidural, we give supplemental doses, so the epidural anesthesia causes less decrease in blood pressure. But the negative point is there can be much more complications with epidural anesthesia in untrained hand, as we had discussed before, total spinal being the worst case or a postdural puncture headache. If we use a epidural catheter, it should be removed before the patient is sent to the ward, usually, unless the patient is sent to the ICU where the patient gets attention throughout. And epidural, as we had discussed earlier, there is a more chance of infection. What are the durations of the local anesthetic agents we use? The shortest acting is chlorprocaine. Intermediate acting is lignocaine or mepivacaine, and long acting is bupivacaine, ropivacaine, levobupivacaine or etidocaine. Lignocaine, the dose is 3 mg per kg body weight, but if you use adrenaline along with it, excuse me, it should be 7 milligram per kg body weight. The adrenaline increases the duration of action and reduces the toxicity of lignocaine. Bupivacaine is a long-acting anesthetic agent. The dose usually is 0.25 to 0.5% concentration, used in surgical anesthesia and 0.125 to 0.25% in epidural anesthesia. If you add ephedrine along with bupivacaine, it increases the duration of action. Levobupivacaine is a recent addition to our drug armamentarium. It is an S enantiomer of bupivacaine. Same dose is used. The only advantage is it is less cardiotoxic than bupivacaine. Ropivacaine is a drug we use quite regularly for pain relief. It is a long-acting anesthetic. The concentration is 0.5 to 1%, or it can be used for analgesia is 0.1 to 0.3%. It is a peculiar anesthetic where the motor system is not blocked so much, but the sensory block is very profound. Similar to bupivacaine in onset and duration of action. And it is less cardiotoxic than bupivacaine. What are the local anesthetic systemic toxicity? Tingling sensation around mouth, drowsiness, hypotension of course, and as I said, seizures. Treatment is ABC, control the airway, the breathing, the circulation. ABC is the treatment of choice in any resuscitative procedures. Give midazolam or pentothal sodium. For seizures especially, pentothal sodium thiopentone is very, very helpful. Give intralipid to increase the blood pressure. What are the exaggerated physiological responses? There can be high neural blockade, cardiac arrest in worst cases, and of course we had discussed urinary retention. High neural blockade causes are due to excessive dose of local anesthetic, failure to judge the patient. If the patient is elderly, pregnant or obese, the dose should be calculated accordingly. Or if the patient is unusually sensitive, or the spread is excessive because of some anatomical abnormality in the spine. To sum up, what are the complications of regional anesthesia? Pain, post-spinal headache, postdural puncture headache, hypotension and bradycardia, hypothermia because the skin vessels become constricted, giving rise to the more blood supply in the central vessels. There can be hypothermia. Nerve damage we had discussed. Epidural or intrathecal bleeding can occur because of inadvertent puncture of a vessel. Infection and urinary retention. Continuing, there can be bleeding from the skin, tissues, spinal column or epidural space. PDPH, transient neurological symptoms we had already said, it is rare but can occur, and total spinal of course we had discussed before. What does total spinal do? It causes hypotension, bradycardia, arms become paralyzed or paresis is there. There can be shortness of breath because the diaphragm is also paralyzed. Patient becomes obviously anxious when the patient can't take normal breath. In worst cases, there can be loss of consciousness. In extreme cases, there can be cardiac arrest or respiratory paralysis because of coning of the medulla. What are the treatments of cardiovascular effects? Best way to treat is physiological, not pharmacological. So what do? Increase the cardiac preload with enough intravenous fluid. If intravenous fluid doesn't bring the blood pressure up to normal, then what we do? We use vasoconstrictors like ephedrine or phenylephrine. In the respiratory system, in healthy patients, I am not talking about patients with COPD and other respiratory diseases like asthma. In healthy patients, appropriate spinal blockade has very little effect. In high spinal, there can be a decrease in functional residual capacity because the diaphragm is blocked, and the abdominal muscles of respiration are also blocked. The intercostal muscles become paralyzed, and in worst cases there can be apnea due to involvement of the respiratory center. So we have discussed today all the complications that may occur in regional anesthesia. If you have any questions, I am telling you again, please write it back and I think I will be able to answer all your queries. Thank you.